Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why.
All right. Good evening, everyone. Happy for those that have taken the time out to join us. I want to welcome you back to our show. I'm dealing with one of my favorite physicians this evening, who happens also to be my physician. I don't have a problem uh, jumping right into it and saying that's who take care of me. I'm still here, so he must be doing a pretty good job. I want to introduce Dr. Christopher Williams. Dr. Williams has been on our show in the past. And so, as most of you who have listened to us in the past know how extremely knowledgeable he is as it relates to men's health, especially as it relates to prostate and prostate cancer. Not saying that's the only thing he knows about, but he's extremely knowledgeable from that standpoint. Dr. Williams, how are you doing today?
I'm doing good, Dr. Kane. Thanks for having me on again.
Appreciate you coming. And we also going to have at the front, on the front line this evening, Mr. Tyrone Jackson. Y'all just excuse him. He'll be okay. Uh, how you doing, Mr. Jackson?
I'm doing well, Dr. Kane, and now being okay, that's subject to determine future determination. So we'll let them make that decision.
All right, Miss Turner, if she's able to join us, emergency came up. If she's able to join us, she will. But in the meantime, it's gonna be us guys. Sorry, ladies, no pun intended, but it's just gonna be us guys this evening having that discussion. I do like to have it where women participate because, truth be told, I utilize them quite often to get some things done as it relates to men's health because they got the big stick and I don't. And so we're going to start out this evening. I'm going to get a real basic question to Dr. Williams, who's gonna, I know he can answer it very easily, but just for those who haven't been able to join us in the past with Dr. Williams, Dr. Williams, what's prostate cancer and why is it so important to me?
Well, prostate cancer is a cancer only in men because only men have prostates, and the prostate is a organ in the genital urinary system, and its primary role is to uh, convert some proteins that are in the prostate to a more usable form for the rest of the body. Um, Not to get too technical, but also the urethra, which is the tube that runs from the bladder out through the penis, runs through the prostate as well, and also emptying into that urethra are secretions from the seminal vesicles, which is predominant source of the ejaculate that empties into the prostate, into the urethra, and that's what ejaculates out. So it's a organ in the genital urinary system that is important for sexual function, but also because of urination and the proximity of the urethra to the prostate, it can impact urination too. Because when the prostate gets very large, it can block the urethra off and makes it hard for the urine to pass through. And now, prostate cancer, you asked about prostate cancer. Prostate cancer is one of the number one the leading occurring cancers in men. And in black men in particular, we have a higher risk of prostate cancer. That's probably somewhat genetic in cause, but it's also environmental, probably a combination of the two things. But the bottom line is because our risk is higher, we need to be vigilant about screening ourselves for prostate cancer.
So, what age should we start screening for prostate cancer? Is there a different age for black men versus others? White men.
Yeah, actually, there is a difference because we're considered a high risk group, as are
Mhm.
people who have family histories of prostate cancers as well. Anybody in the high risk category, the recommendation from the National Comprehensive Cancer Network is to begin screening at age 40. And that screening should consist of a blood test called a prostate specific antigen, or PSA. That's something that's only made by the prostate and the seminal vesicles. And the other part of screening is a digital rectal exam where the doctor puts their finger in the bottom and feels the prostate for hard spots that could be the first evidence of prostate cancer. And it's important to do both because by doing one or the other, you could potentially miss the prostate cancer and catching it early. And I often do find a abnormal rectal exam in people who have a PSA that's not technically high. So it's important to do both, especially in the high risk groups like we are in as African Americans, because the point of the matter is to catch it early enough to be able to treat it before it is spread outside of the prostate. Because once it's spread outside of the prostate, it can't be cured. It can often be controlled for a time period, but it cannot be cured. So we want to catch it before it spreads.
Well, you answered several of the questions I had, because one of the things that I get most resistance from men, especially black men, is doing a digital rectal exam, because they're frequently saying, "Hey, why should I do that when you guys have a blood test for prostate cancer, and that should be able to tell us whether or not I have cancer?" So I get a lot of resistance from men for that so-called DRE, or digital rectal exam. And what's your thought on that? How can we encourage them to be more cooperative in terms of bending over?
Well, I hope that what we're doing tonight will help people. It's education, helping them to understand that you can miss about 15% of cancers in men who have a PSA that's less than 4. 4 is even an old cutoff. We don't use 4 anymore. We use 3 per the National Comprehensive Cancer Network guidelines. And so you can miss a significant amount of cancers by just doing the PSA alone that you may be able to pick up sometimes with the digital rectal exam. And I think it's important to just keep stressing that we're a high risk group. So we're not only high risk of getting it, we're high risk of dying from it, because when we're diagnosed, it's often at later stages, later grades, higher levels of difficulty in managing it, and higher risk of it spreading. And so we want to do everything we can to try to catch it early. And so if it means just putting a finger in the bottom as an extra step to try to catch it early, then that's what we should be willing to do, because prostate cancer diagnosis doesn't just affect the man; it affects his family as well. Because if you're out of commission, because of your prostate cancer, then you can't, fulfill your duties to your family as well. So that's another thing that we need to make people aware of, is regarding prostate cancer screening too.
And those duties is specifically what men, when we start looking at talking about those duties, don't forget, I may sound a little bit chauvinistic here, but particularly when we start being viewed as the head of the household, and that your family depend on you, but not only for financial support, but for guidance. They want you around to educate, particularly those with sons, to help educate those sons and those daughters as to surviving this hectic world that we're in. So that's one of the things that Dr. Williams is referring to, not just from a sexual standpoint, in case anybody was misunderstanding or misreading what he's trying to indicate when he says you have to be around to perform your duty as a male. It ain't just from about the sexual orientation. It is about your duties to your family and loved ones.
Right. That's exactly what I was inferring. I wasn't even speaking about sexual at all.
Well, I know it, but sometimes we have people. Sometimes we have people that misread what we say, so you have to make sure they understand. So,
but we also have to be honest and understand that the sexual is very powerful. When you look at the history of African American men and their relation to strength, worthiness, and acceptability to society, it has been greatly related to their sexual prowess. I mean, when you go all the way back into slavery, when they had breathing camps and these things. So we, as a group of men, have been conditioned by society to associate our value with our sexual prowess.
yeah, not going to disagree with that one. I'm not saying it's right, but I'm not going to disagree with it, in terms of what you're referencing. So I can concur. And that's what a lot of men, that's where the ego hangs. which is another way of stating what you're saying, Tyrone, that sexual prowess, is a lot of that we hang around our neck as far as our ego is concerned. At least I see quite a few of them. It's interesting that Dr. Williams, that when you mention the, the new value for the PSA, it's still coming out in most of these labs are still using 4 as being within the range of normal.
Right. Yeah. Yeah. That's
So,
that's problematic because we moved on from that many years ago as urologists because we found that value was it was too high. The threshold at 4, we started missing too many cancers that were occurring prior to that, and that's why the National Comprehensive Cancer Network, through their research and studies and consortiums, decided that 3 was a better number. And so, the only thing we can really do from that standpoint is to try to educate. Like me, I have to tell you, Dr. Kane, because you're a family practice doctor, and I have to make you know that, hey, I'm looking at 3. If it's 3, let me know about it so I can help take care of these patients. And then you have to pass that on. And I gave a talk to the Florida Osteopathic Medical Society, Association, a few months ago, and I was telling them the same thing and showing them the NCCN guidelines and telling them that, hey, we moved on from 4 a long time ago. I know that a lot of you guys didn't get the memo, because a lot of times, as you know as well as I do, the associations that kind of run our different specialties are different. And so, whereas, you might be, concentrating more on diabetes and high blood pressure and things of that sort, my organization's focus is going to be on urological things. And then, the 2 different associations don't often mix. They don't work well together sometimes. And so that's bad for the patients. So we just have to kind of, help each other. I have to let you know, hey, I'm looking at a cutoff of 3, and you pass that on. And when I have a chance to talk to different organizations of primary care physicians, I have to let them know as well, that PSA cutoff of 3 is really what we're looking at. And another thing that I want to point out too, and I have to always remind people too, is, you know, the trends are important as well, because at the end of the day, we're trying to find cancer early. So if your PSA is 1 year, 1.5 the next year, 2 the next year, my ears are already going up. I'm like, hey, what's going on? We're heading in the wrong direction. And
right.
so even at that point, we might start saying, hey, well, maybe we need to start checking this PSA a little bit more often. Let's make sure we got that DRE done, just to make sure that we're not missing something that we could catch early, because many times the most aggressive prostate cancers are not behaving like prostate tissue anymore. Normal prostate tissue makes PSA, but if the cancer is not behaving like normal prostate tissue anymore, maybe that PSA doesn't get so high. And maybe
Mm.
before by the time that PSA reaches a quote unquote abnormal number, that the cat might be out of the bag. So we want to make sure that we check trends as well and hop on that and make sure that we diagnose things as early as we can.
Yeah, when you say trends, what I do emphasize to some of my patients is the rate of rise. 1 year you may be at 0.5, and then I get you the next year you're 2.5. That's two and
Oh
a half.
yeah,
Yeah,
yeah, that's yeah, and the NCCN, I think they say that they don't really encourage using PSA velocity, the rate of rise. But I
okay,
mean, common sense is if you see something going up, I'll use the analogy when I have patients in the office. I say, if you had your grandchild with you and you saw a car coming down the street and your grandchild was running toward the street, you wouldn't say, well, he's not at the street yet, so I'm not going to call him. I mean, you're going to say, hey, stop, well before he even gets close to the street.
right, right,
And the
right.
same thing with this PSA. If it's starting to, you know,
Creep up.
progressively go up, we
Mhm.
need to start taking note of that and start to do other things to try to see if there's any way of detecting this thing early. Because if this might be the kind of cancer that, is a really bad player. People always talk about prostate cancer not being, fast growing and things of that sort. But the problem is that that's not all prostate cancers.
Right.
Mm.
Not all prostate cancers are the same. And you can have some that the fancy word for it that are poorly differentiated, which means that they're not behaving like normal prostate tissue and they're not making as much PSA. but they can still be very, very aggressive prostate cancers, and those are the ones sometimes that will spread quickly. And so we want to take every opportunity to find whatever signs we can of cancer and try to make that diagnosis early.
Now, Dr. Ken Jones had two questions. The first question, I want to answer that later. I'll ask that shortly, but I would like to answer this last question he had, and that was, what would cause a PSA to decrease or fluctuate in terms of its value?
Hey, that's a wonderful question.
Exactly.
And I like to tell people, I have to remind them. So what does PSA stand for? It stands for prostate specific antigen. And antigen is just as a marker, a protein. And so, but it's prostate specific. It is not cancer specific. So
Right.
other things that impact the prostate can make your PSA move. And so infection, inflammation, trauma, all these different things can have an impact on your PSA because they impact your prostate. And so again, prostate specific, not cancer specific. And so, for instance, I'll give you one example. So I've in the past had some young men come in and their PSAs were way high for their age. I'm like, wow, this is just way too high. And
Right.
but the young man is a picture of health. And I ask him about his activities and find out, oh, he's an avid bike rider, for instance. And
Yeah.
so he rides on that tiny little seat. He's essentially sitting on his prostate, and he's riding 30 miles a week, 40 miles a week, so he's really traumatizing that prostate. So there's a lot of inflammation in that prostate, and that can make that PSA go up because it's prostate specific, not cancer specific. So that's just an example of things that can make your prostate fluctuate. And also infection, I mentioned infection too. So if somebody comes to you and they have some signs and symptoms of prostatitis or inflammation of the prostate, that's the worst time to check a PSA because it's going to be abnormal. It's going to be high because it's inflamed. And so you would want to manage that first before you repeat that PSA.
And a lot of times you don't know it's inflamed or irritated to any degree. So,
yes.
And that was going to go to one of these other questions that Dr. Jones is asking right about now. The effect that sexual activity has, not just in the long run, but what about in the short run? So, for instance, sometimes we have patients, it's been mentioned about some of my patients, they may have had sex the night before they went and had their blood drawn and got their PSA. What is in that might affect the value that we get. That myth, what do you think? What's your comments on it?
Yeah, so there is literature to support abstaining from sexual intercourse for at least 48 hours prior to a PSA draw, because it can impact it some. The amount that it should impact it should not be great, but remember, sometimes we're talking about tens of points. So what if that PSA that you've been watching is just under that 3 threshold, but you ejaculated the night before and that pushes it over. Now you're concerned. So if you can have them abstain from sexual intercourse for at least 48 hours prior, that would be helpful, so that we don't have these values that just kind of put us kind of in limbo. Like, what do we do? Is this real or not? But just that I mentioned that, though, whenever we have a PSA that's high, the first thing we want to do is repeat it.
Yeah.
We first of all, we figure out, okay, what else could be causing it to be high? Is it infection? Is it inflammation? Is it just enlargement? Now, the enlargement part can be a little bit tricky because, a really big prostate often will make more PSA, and then you still won't be able to know whether there's cancer or not. But we do want to repeat that PSA and find out, hey, is it still high? And first of course, you mitigate any factors that could be causing that PSA to be up that's not related to cancer. And then I'll answer that question. Just leave it at that for now, and then later on we can talk about some other ways of kind of adjudicating a PSA that might be a little bit kind of in limbo. Not quite high, not quite where you want to jump off and do a biopsy and stuff. There's some other things you can do.
Yeah, because some of the patients, what you wind up when you're doing the testing, it comes back elevated, more so. I mean, again, because LabCorp and Quest still using the old 4 bag.
Yeah.
Okay, which they need to change. I don't know what we can do to help advocate for that change, because the patient's going to look at their labs And these days,
Right.
since they have access to their lab, they look and say, "Oh, it's in the normal range," and then I don't care how much we try to call and catch up with them. Sometimes they figure, "Well, I don't know what he's calling about. Maybe he just wants
Yeah.
some more money or something." He's coming to the office. It's like,
Yeah.
no, not really, but we
Yeah.
need to follow up on that. So, um, what can we do to kind of help get that? uh, When I'm talking we, meaning physicians, and I guess physicians organization, what can we do to help try to get that change officially notified within these different labs?
I'm not sure, Dr. Ken. I've thought about that for many years, because I would have thought that like the American Urological Association, which is the largest, medical association that represents the urologists,
Right.
basically in the world, that they would have, over the years, told these labs, okay, we're using a different value now, et cetera, et cetera. But it just never has happened. And I just wonder why they wouldn't do that. I don't know why, but it's been like that for a decade or more,
Right.
and nobody's made the move to change. I don't know. Maybe they reach out to them and they just said they didn't want to. I don't know. I have no idea honestly why they haven't made that change. So I don't know how to answer that one for you.
And just for clarification, sometimes when people talk about sexual activity, you and I talk about sexual activity immediate, more or less, to obtaining the blood work. I guess another point of view from that question is, well, what if I'm not that sexually active? Does that play a role in my ability to have prostate cancer or not? I mean, I know what my answer would be, but I'm asking an expert just to be sure.
I've never seen any literature that, definitively said that there was a correlation between, inactivity and prostate cancer. So, I couldn't say that there is. I doubt that there is, but I don't know. I've never seen any literature that would support that there's a, connection between, sexual inactivity and prostate cancer.
You just hadn't found the literature.
Yeah. And it just in my experience, because, um, I see different kinds of patients, some sexually active, some not, and I don't really see just a basic correlation just on the surface either. So I would think that it probably does not, but like I said, no
Okay.
literature that I know of that supports it.
All right. So now I get back to Dr. Jones' original question. Other than the PSA, is there a circulating prostate cancer antibody that could be detected in blood as well? Other circulating antibodies or whatever markers that can also be indicative of prostate cancer.
Yeah, there are different like isoforms of PSA. Those are not as mainstream as the biomarker testing is now, and so there are different genes that are associated with more aggressive disease, more aggressive prostate cancer, or in some cases are called biomarkers, different proteins that are similarly connected to aggressive prostate cancer behavior, and those can be detected in the blood and or the urine, and to give a genomics, what they call genomic tests, to determine what somebody's risk is of harboring aggressive prostate cancer. I keep harping on aggressive prostate cancer because these tests are designed only really to detect risk for aggressive disease. And the reason why they have been engineered that way is because the recommendations from the big organizations like the American Urological Association is going to always be for low grade prostate cancer that it should not be treated. It should be observed. It should be active. It should be actively surveilled. And so because of that, then all the tests are geared toward detecting disease that you're going to treat, not disease that you're going to watch. But there are a lot of different tests that you can use, biomarker tests. I don't want to, promote any one over the other, but there are a lot of them. There's some urine-based ones. There are some blood-based ones that can be used, and I find them to be very helpful, especially when I'm trying to, determine whether or not this elevated PSA does it warrant a biopsy? Because in some cases, my suspicion might be that you know um, the PSA elevation may be from another cause, or and this is very important too, Dr. Kane. the reason for diagnosing prostate cancer is to make sure that somebody who would otherwise have a 10 to 15-year life expectancy is not robbed of that by prostate cancer, okay? Because they've done many studies in men who were like 80s years old who died of other causes, and they checked their prostates, after death, and the majority of them had a large majority of them had prostate cancer, but that's not what killed them. And so we don't want to diagnose prostate cancer if we don't think that it's going to result in treatment that's going to help them live longer. So that's really important too. So we don't overdiagnose people. And
So,
sometimes having these biomarker tests can help with that. For instance, if I have a gentleman, let's say he's 75 years old, but he has, heart problems, other medical problems, you know, but he's had his stents placed in his heart, and they think he's doing okay right now. But he's not the picture of health, though. But he's still really concerned that if I have prostate cancer, I don't want it to kill me. Well, then I might say, okay, your PSA is 6, um, but let's do a biomarker test. If it comes back low risk, meaning low risk that you have we would find aggressive prostate cancer if we did a biopsy, then we might continue to follow that PSA. And if it doesn't, continue to go up and just kind of levels out around 6, maybe we don't do anything. So that's sometimes how we use it. But if it comes back high risk, well, then that person probably should get a biopsy because he might have the kind of cancer that's going to be a problem for him. It may kill him at some point. We don't want that to happen.
so are we saying that at an age, because that's one of the things that people do ask, what age should I stop getting PSAs done?
Mm-hmm.
I'm,
Well,
I'm 75. Should I still be getting a PSA? I'm 80. Should I still be getting a PSA and so on and so on? What's your talking points on that?
well, the National Comprehensive Cancer Network says for people who are over 75, then you should consider doing a baseline PSA. And if that PSA is less than 4, and if you do the rectal exam, which we do recommend doing the rectal exam, because again, if we're considering not screening somebody down the road, we want to make sure that we've, dot all our I's, cross our T's. And so if the PSA is less than 4, the rectal exam is normal, and there's no other indication for a prostate biopsy, then you could consider discontinuing screening if it's clinically appropriate, or you can repeat testing at a 1 to 3 year intervals. Okay. But you could consider like discontinuing at that point. Now, if they're that age and they don't have a 10 to 15 year life expectancy because they have so many medical problems and they're at risk of dying from something else much sooner than later, then it doesn't make sense to even check that person for prostate cancer because that's not what's going to kill them. And then many times if we make that diagnosis, now everybody's focusing on the prostate cancer and not the things that are immediate that's probably going to kill them, like their heart or their lungs, things of that sort. And so, but if their PSA is greater than 4 or they have an abnormal rectal exam, then that person should be considered for biopsy just like anybody else at a younger age. I think that it's not right to just exclude people just based on age. I think we need to definitely look at, life expectancy and their overall condition of health too, because we all have those patients who come in and they tell us they're 80 years old and we can't even believe it because they look like they're 65.
Right.
And that person, we're like, hey, and you ask the person, I'm a big person, I ask them, how old did your people live to be? I say, how did your mom live to be? How did your dad live to be? And they say, mom and dad, they were 90 or whatever, 95, 100. Then that person has a 10 to 15 year life expectancy as long as they don't have any other medical problems. And I'm going to screen that person. I don't want that person to die of prostate cancer.
Right. So you're kind of saying that it should be individualized and, look at each person as an individual to help determine the aggressiveness by which you may want to work this up. Is that correct?
Yes. I think it should be individualized. And, the buzzwords these days are, doctor patient. Yeah. Doctor patient, shared decision making, those kinds of things. And that's important, especially in that particular case, because it seems kind of wrong to tell somebody, yeah, you're so old, we should let you die of prostate cancer even if you got it. I'm like, no, that's not the right way to go about it. I think we should give them the evidence that we have and go from there.
I can't go without this making this statement when Dr. Jones says So do priests have a higher incidence of prostate cancer? I was expecting to answer that question, but I had to
Yeah,
throw
I don't know.
it out. So the all right. So other than let me give you a scenario. I got young. We have young. A lot of our primary care physicians are women. So
Hmm.
now, this prostate cancer is a disease for men, and you mentioned about digital rectal exam. A lot of these guys, they don't even want me doing the digital rectal exam, no less having a female do it. What can you? I mean, I know you can't have one size fit all for that to answer to that question, but what would be maybe if I'm a female family practitioner, how would you expect me to handle that? What's the best way you think I can handle
Well, I mean, you certainly can't ever, force your way onto somebody, even if it was for a good reason, to help screening for prostate cancer. But, if they said, hey, I'm uncomfortable with you doing it because you're a female, then if they have a partner in the practice who's a male who'd be willing to do it, or another practitioner, a PA, nurse practitioner, somebody who's male in their practice, and they could see if they could do it for them. Or like I've told you before, and everybody can hear me. I tell Dr. Kane before. I said, if you don't want to do it, send them to me. I'll do it.
it? Right.
And
And I
they,
would in a
yeah,
heartbeat, I will send them right to
yeah.
you.
But the only problem with that, though, Dr. Kane, is that the insurance companies don't like to pay for screening. So if you send a patient to me sometimes, then we have a hard time getting paid for that visit because it'll be a prostate cancer screening visit, and the insurance don't want to pay me for it.
got it.
So that's the only challenging part. But so the short answer is to try to get somebody who's their partner or somebody else who's a male to do it, so the patient doesn't have to go without being screened. And push comes to shove, try to have it done by a urologist. Maybe if they have some other urological issue, like BPH like symptoms or something like that, that could be the reason for the referral. And then, oh, by the way, he needs to have his prostate checked. You know.
Yeah, well, and because a lot of times that you have some physicians don't feel comfortable at being able to do an adequate prostate exam. I'm not
Right.
talking about urologists. I'm
Hmm.
referencing particularly some of the younger physicians, younger male physicians included,
Yeah.
that they don't
Now,
have that confidence level.
and one of the things I heard you mention earlier, Doctor Williams, is that the importance of education.
Hmm.
This is I think this question that Dr. Kane poses a great question for the understanding of educating men on the value of the digital rectal exam
Right.
as a combination with the PSA.
Hmm.
Uh, I've because I've had the conversation with friends of mine, and they were saying that they had a female primary care physician, and then by the end of the conversation, helping them to understand the value of this is for them, and that's something that you need to work through in your own head because the value outweighs the embarrassment.
Yeah. Well
Exactly.
said. Well
Well
said.
said. Well said. Okay, so how do family history and genetics affect prostate cancer risk? I know we kind of discussed it at a higher level in terms of African Americans. Anything else that can put people at a higher risk for prostate cancer? Say my mom has breast cancer. Am I at a higher risk for having prostate cancer?
Right. So, you know, a lot of people don't understand that there are many of those genes or biomarkers that are associated with aggressive prostate cancer are also, associated with like breast cancer and stuff and things of that sort too. Like the HER2 gene, those that can be in prostate as well. And so many times it's also recommended, like in patients who have aggressive prostate cancer, that they have what's called germline testing. So they'll basically, take their blood or saliva or something like that, and they'll try to determine whether or not they have any of these high risk genes um, in their germline, because that's something that can be passed on, to their children, and it could also be something that's shared by them and their siblings. And so if like your mother had aggressive breast cancer and she died early, 50, something like that, then she might have like a gene that could be passed on, to her children. And then that can be tested for that. And if you have that kind of gene, germline mutation in your family, in your family history, then those patients need to be screened earlier for different types of cancer that are associated with those mutations. And so the NCCN guideline, talks about genetic and familial high risk assessment for like breast, ovarian, pancreatic, and prostate. So if you have any of those kinds of cancers in your family line, especially diagnosed early, like in the 50s, things of that sort, and also especially if they were aggressive behavior, like resulted in early death, things of that sort, then those people is recommended to have genetic testing to see if they harbor any of those types of genes that can be passed on and be responsible for the aggressive behavior of those different types of cancer.
Well, given that scenario you just described, if I am my mom did have, say, HER2 positive, genetic marker, blah, 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 blah. I'm a 20-year-old versus a 30-year-old versus a 40-year-old. At what age do I get aggressively look at screening those individuals?
Yeah, that's a hard question to answer because everything kind of boils down to what their insurance is going to pay for, And but the best answer for that would be the earliest screening that is recommended for high risk individuals would be the starting point. So, for instance, if your mom died of breast cancer at age 50 and she had a BRCA2 gene, and it was thought to be responsible for the aggressive behavior of the prostate cancer, of the breast cancer, excuse me, then you should start getting screened at age 40, okay? Because that's the earliest because that's what the high risk individuals are recommended to be getting screening. And for most of the other like cancers and stuff like that, I think 40 is probably as low as I've seen any recommendations, from guidelines and things of that sort. Now, certainly people can have things earlier. The difficulty is getting people screened earlier and having it paid for because, we have Chadwick Boseman, he died. He was just barely 40, I don't think, if he was 40, and
Like
so if he had been screened a lot earlier, then maybe they would have caught that earlier. But again, there are no guidelines that say start to get screening at age 25. You're not going to find that in anybody's guidelines. And so the best we can really do is the earliest that is recommended for high risk individuals to be screened is when you should start getting screened. And if you have the means, obviously, to pay out of pocket for these screenings, then you can get them done even sooner. And it may save your life, but not everybody has that ability. And so it's kind of frustrating because it presents kind of a two-tiered system, the haves and the have-nots.
So are they very expensive? Just since you went across that threshold.
Well, certainly it's not that expensive to have a rectal exam and a PSA. That's not very expensive.
No, not that. Yeah, no, that's easy.
Yeah, that's easy. And then of course, for breast cancer, they can do a self-exam for their breasts, but it's more challenging when you start talking about like CT scans and MRIs and things of that sort for like pancreatic cancer and colonoscopies for colorectal exams. And just remember, the Cologuard that everybody's talking about now, that's not for high risk individuals. They even say that. That's really important. You know that though.
Yeah.
And that's one thing I've talked to people about before. They're like, well, I did the Cologuard. I'm like, hey man, you're a high risk individual. That's not for you. You need to have a colonoscopy.
Right. In which they don't want to do it, but it's like, look, you can. Sometimes I use it as leverage, but you can go ahead and pay for the Cologuard, but if it come back positive, you're gonna do the colonoscopy anyway, and you're high risk. Why not just going ahead and do the colonoscopy up front? Right. Okay. All right. Well, now that can lead into Dr. Jones wanted us to discuss the sensitivity of an MRI in the diagnosis of prostate cancer.
Okay, so that is MRI is often being used now as part of prostate cancer screening, but also detection. And so MRIs have gotten pretty good at showing areas in the prostate that might represent aggressive prostate cancer. Okay, that's how it's set up. Again, just like the biomarker test, everything is set up to show aggressive prostate cancer. That's how they're set up. And so If somebody has a elevated PSA and I've determined that they need a biopsy, that's when I'll order an MRI. And if the MRI shows an area that looks aggressive, then I will target that area at the time of biopsy. It's called a fusion biopsy. So basically, the MRI images are fused with the real-time ultrasound images, and then I'll do a biopsy of that area to see if what that cancer is. Now, that's how I use it. Some other people will use it almost as a screen. They'll basically start off with, okay, high PSA, let's get an MRI. If the MRI is negative, we're not going to do a biopsy. I do not believe in it being used that way, especially in high risk population, and also from my own experience, because I noticed that it seemed like, man, in Black men, a lot of times I would have discordance between my MRI and my biopsy. I'll have a biopsy that has this aggressive looking area. I biopsy, it's either negative or it's a low grade disease. I'm like, whoa, that's not helpful at all. And I recently have seen a couple of articles that spoke to that same scenario where it wasn't correlating, in African Americans. I don't know why that is, but that's why I always use the MRI after I've already made a decision to do a biopsy. I said, I'm going to be there anyway. If there's something to target, I'll use the MRI for that. But some people, like I said, they will use that exclusively to determine if a biopsy is indicated. And that's not right for my practice for the people that I see.
Now, one of the things I've heard you mention, and wouldn't mind if you would speak just a little bit more on it, is the active surveillance. What
Okay.
is the qualifications for when you would recommend active surveillance versus another form of treatment or more test?
Yeah. So when people have low grade prostate cancer, so prostate cancer is not deemed to be aggressive, or they have intermediate risk prostate cancer, but it's on the non-aggressive end, because you can have intermediate prostate cancer that's considered favorable risk, and you can have unfavorable risk. The unfavorable risk is at risk for becoming more aggressive or spreading things of that sort. But if you have the favorable risk, intermediate risk prostate cancer, or low grade prostate cancer, then the option for active surveillance is there. And what that means is we think this is a cancer that we found that's not going to become a problem for you. It's not going to spread. It's not going to lead to your demise. It's not going to invade, other structures. And so watching it makes sense, because every treatment option for prostate cancer, active treatment option, has some side effects associated with it. So if we can just watch this, then you can avoid those side effects. Now, how do we do active surveillance? It's a very active process, hence the name. So the first thing we do is we repeat the PSA periodically. Every 3 to 6 months, I use 6 months usually. We repeat the PSA to make sure the PSA is not continuing to go up. At the initial start of active surveillance, I like to do one of those biomarker or genomic tests that we talked about earlier to see, from a genomic standpoint, what is the risk that this prostate cancer is going to behave badly. And if that risk is low, we continue with active surveillance. That risk is high, we do not continue with active surveillance, or at least I let the patient know the risk is high, that you're going to progress and you might need to go ahead and start thinking about active therapy at some point down the road. And so the other thing we do with active surveillance is we repeat the MRI. I repeat it usually at 1 year, because I'm going to repeat my biopsy at 1 year typically. And then, of course, I do the biopsy at the 1 year anniversary typically. The only thing I changed recently, I saw some literature that supported something I had long suspected, that if somebody has a negative MRI initially and they have low grade disease on their biopsy, then we can potentially omit that 1 year biopsy in favor of just doing the MRI. But that you have to do that on a case by case basis, see what the genomic score looks like and things of that sort. But that's active surveillance. Basically, we're not going to treat the cancer. We're going to watch it very closely with PSA, MRI, repeat biopsy, and even genomic testing in some cases.
Okay. And then another thing that I hear often spoke of with regards to a prostate cancer is a Gleason score. Can you give us a little explanation of what that is?
So what a Gleason score is I guess Gleason was a pathologist, I'm assuming, but it's a pathology reference. So how aggressive the cancer is under the microscope, and basically that's based on how much it looks like normal tissue. So a low grade tumor or cell, a prostate cancer cell, looks very much like normal prostate cell, except for some minor changes, okay, that pushes it over into being a cancer. But it's still low grade, it's still not aggressive looking. An aggressive looking prostate cancer cell sometimes looks very little like prostate tissue anymore, but we know it came from the prostate because we took a sample from the prostate. And that's a very aggressive looking prostate cancer. So that the Gleason's grade is a way of grading the cancer. The lower the grade, the lower the aggressiveness. The higher the grade, the higher the aggressiveness. And the score, you get two numbers. So the first number is what grade of cancer do they see under the microscope predominantly? And then the second number is what's the next grade of cancer that they saw the most under the microscope. So if you started off with very low grade and you saw 3, mostly grade 3 cancer, and then you saw a little bit of 4, you'll be a 3 plus 4 equals 7. If you saw mostly 4 under the microscope, but you saw a little bit of 5, you'll be a 4 plus 5 equals 9 prostate cancer. If you only saw one grade of cancer the whole way through, then you get that number twice. So if you only saw 3 and nothing else, you get a 3 plus 3 equals 6. And that's low grade prostate cancer. The highest you can get is 5 plus 5 equals 10.
Okay. So.
And the lowest you can get is 3 plus 3 equals 6. So.
Okay. It's 6. Okay. All right. Mm-hmm. So does every guy you get, do you do a MRI before every prostate biopsy that you have
yes.
Plan on doing?
Yes, I do. Why? And like I told, because if there is a spot that looks aggressive, I don't want to miss it, because we can't biopsy every single piece of tissue in your prostate. We'd have to turn your prostate into a pincushion. So what we do is we focus on the peripheral zone. That's the kind of outer area, the outer edge, so to speak, of the prostate, outer third or so we'll say. And that's where prostate cancer occurs most often, in that peripheral zone. And so that's where we're gonna focus on. We're gonna take the majority of our biopsies from there, and then I may take 1 or 2, well, 2 usually I take, in the anterior part of the prostate, higher up away from the peripheral zone, because sometimes you'll find some cancer there too, but that's not the predominant area we're gonna find it. So I won't take as many there. But if I have an MRI that shows a lesion outside of that peripheral zone that I was otherwise going to miss, I don't want to miss that. If it shows up at the MRI, I'm going to go get it. That lets me know I need to go to that area and biopsy that area. So I do an MRI on every patient before I do the biopsy.
So it doesn't pay, because I know I've had a patient recently that the physician was just going to go in and do a biopsy of prostate. I said, did they do an MRI already? He said, well, no. And I said, they plan on doing an MRI. He said, no. I'm going like, I think I need to send you somewhere else. Let me get a second opinion on that.
Yeah, I think a second opinion is wise, and I can't say what that doctor is doing is wrong, but right. there's a better way of doing it.
There's a better system at doing it.
There's a better way of doing it.
All right, yeah.
So with that, when you're doing a biopsy, what should men expect in terms of coming up to that biopsy and maybe post-biopsy care?
Well, there are basically 2 approaches for doing a prostate biopsy. You can go through the rectal wall. We know the rectal wall is very close to the prostate because we can put a finger in your rectum and feel your prostate.
Right.
But there actually is a space between the rectal wall and the prostate, but it's so thin that you can feel the prostate through it. So you can go directly through the rectal wall into the prostate and take your samples with a needle that way. And you can also go through the area called the perineum. The perineum is the area between your legs. So it's between your scrotum and your anus, that area down there. And this prostate is right behind there. So you can go directly through the skin into the prostate and take your samples that way. And how, which way you go is the preference of the surgeon and also the patient. Again, shared decision making, because there are some potential advantages. The biggest potential advantage, and I say potential because a lot of the randomized controlled trials don't bear out this particular advantage all the time. But so if you go through the rectum, there's a higher risk of infection because nobody's rectum is clean. So you have to give antibiotics to try to decrease the risk of infection. But many times that's guesswork, because a lot of times with the rising rate of antibiotic resistance, people are resistant to antibiotics and don't even know it. And so
Right.
you could do the biopsy having given them a particular antibiotic, not knowing that they're resistant to it, and they get septic. They get a bloodborne infection from it and get really sick and have to be hospitalized, get high fevers and stuff. Another way to do it is to take a sample of stool from the rectum and send that off to the lab and test it against different antibiotics to see if they're sensitive or resistant to different antibiotics. And if they're sensitive to one, resistant to another one, to make sure you give them one that they're sensitive to. So that's the transrectal biopsy. So through the rectum. The transperineal route, though, bypasses the rectum altogether. So potentially less risk of infection because you're not going through the rectum. Okay. And that's the biggest benefit of going through the perineum versus the rectum is decreased risk of infection. But the trials that I've looked at have looked at giving antibiotics for the transrectal approach versus no antibiotics for the transperineal approach, and the risk of infection is roughly the same. You know, there's not a clinically significant or a statistically significant, decrease in infection. And so the transperineal route, even though it's touted as being better, in reality is not better. But again, it does make sense that it should be less risk of infection. And not everybody also on the transrectal side will do the sensitivities of the antibiotics to find out which is the right antibiotic to give too. So that
Mhm.
makes it a little bit more risky to do. And that's the biggest difference in those types of biopsies. What the patient can expect afterwards is some blood in the urine for a few days at
Mm-hmm.
most, not very long though. If you do it transrectally, you may have some blood in your stools for a few days. Blood in the ejaculate for several weeks because your ejaculation comes from the seminal vesicles, which empty into the prostate, into the urethra. And so if you have blood in the prostate from the biopsy, when you ejaculate, it's going to pick up that blood and carry it out. So that takes a while for it to clear up. And that's going to be the case no matter whether you do it transrectally or transperineally. That's going to be the same. But in terms of blood in the stools, you have it less for the transperineal route. And for the blood in the urine, it's probably about the same. And those are pretty much the differences.
How do you make a determination which one you're going to do? Is that again?
I do all of mine transperineally. Um, Another thing I should have mentioned too, the cost for a transperineal biopsy is higher because you have to do a block, a perineal block. It takes longer in the clinic. It's harder to get the patient numb than the transrectal route. And so I do all of mine under anesthesia to try to make sure that the patient is as comfortable as possible. And so
I'm a whip,
I
so I prefer the anesthesia.
yeah, so I do mine under anesthesia that way, and also because the patient is completely comfortable, I can take my time, make sure I hit my spots like I want to. So that's a benefit there too. But it is a lot more expensive to go to sleep because you got to pay the anesthesiologist, you got to pay the
Yeah.
hospital fees, you still got to pay me. So it gets pretty expensive to do it that way. And if you do a regular like a transrectal biopsy, that's usually done in the office, and that can be done very quickly in a matter of like 10, 15 minutes. So it's a lot cheaper, for people to have it done that way.
And I think sometimes these insurance companies try to lean to the more cheaper one.
Yeah, yeah, that's true. I
I've
mean,
seen that.
I can understand why. I mean, it's a big difference in cost, I'm sure.
Well, and all we hear as when we talk about prostate cancer is the value in early detection. So, if you could, Dr. Williams, if you could speak to the advantages of early detection over later detection, even up to the point where I hear some have to actually have the prostate removed. As we talk about this here, one of the things that we continue to hear, continue to echo, is the value of early detection and the increase in options it gives the patient. So would you mind speaking to that?
Yeah, certainly. So if you detect the prostate cancer early, meaning that it's still confined to the prostate, then it's still curable. Okay. Once it has moved outside of the prostate, it is no longer curable
Mm,
because it has moved outside the prostate, and you cannot really determine where all it has gone and where all it will go. You can predict, but you don't know for sure. And the treatment options narrow down significantly when it's spread outside the prostate. But when it's confined to the prostate, then you have, many options. We talked about active surveillance where you're just watching it. You could remove it, you can radiate it, you can freeze it, you can use high intensity ultrasound on it, you can treat, part of the prostate if there's only one small lesion. So you have a lot of options available to you as long as it's confined to the prostate. When it's moved outside of the prostate, now you're looking at systemic therapy. So you're talking about therapies that go through the bloodstream, throughout the body to kind of seek out these prostate cancer cells and kill them. But that, usually has a lot of effects on other cells as well. The cornerstone of treating prostate cancer that's spread away from the prostate is to take away the testosterone. It's called androgen deprivation therapy. So when you take away the testosterone, that's what the prostate cancer loves to use to grow. You take it away, you're basically starving it, but you're not killing it. Okay, just taking the testosterone away will not kill the prostate cancer. It may make it dormant for a while so that it can't grow, but it will not cure it. It won't cure it. It won't kill it. Eventually, it'll find its way around it and start to grow again. And then you have to use something else. It might be chemotherapy. It might be immunotherapy. But these are all systemic treatments, and they have other side effects too. Big systemic side effects that make you kind of feel bad and have other adverse, effects on your body. But while it's localized to the prostate, you can do those other things that I talked about. Even though some of them have other side effects too, they're not usually systemic side effects. They're not affecting your whole body. They're just affecting the area where the prostate is.
I know we were trying to keep this mostly to discussion in terms of prostate cancer detection, not as much as totally about treatment, even though we have ventured into that quite a bit. What should men ask their physician if they're told they need more prostate testing?
If they're told they need more prostate tests?
Testing, yes.
More prostate.
Yeah. What question one ask, and so on and so on.
Well, if they said they need more testing, the first question is, what is my current PSA? Because that would kind of help decide, how urgent it is to repeat it. Because if it's already over 3, then you want to repeat it right away to make sure that that is a good value or not. If that's legitimately still high, now you're talking about considering, biopsy, and you have to decide at that point if you're going to do any biomarker testing or MRIs, et cetera, et cetera. But if the PSA hasn't reached that 3 threshold, but it's close, then you might want to repeat it in 3 to 6 months or something like that. If it's far away from that, for instance, the NCCN guidelines I'm gonna stay with high risk patients because I think most of our patients on this call are probably African American. If the PSA is less than or equal, we'll say it's less than 3, then you can repeat the testing at 1 to 2 year intervals. And then for younger patients, you could consider, stepping that up a little bit too, if you don't want to, miss anything. But again, I always kind of, like we started out talking about, I like to know what the history of the PSA is too. So
Right.
What has it been doing prior to, because that should also kind of inform how quickly you want to repeat that PSA too. And then of course, doing the rectal exam for completeness, making sure you're not going to miss something there that's going to jump up and bite you, and you're not going to find out about it until your PSA gets over 3, several years from now. But by then, maybe the prostate cancer has already spread. So.
I tell people that testosterone will fertilize for
prostate cancer,
much like fertilizer for breast. So keep that in mind in terms of looking at that.
Right. We get
I'm sorry. Go ahead.
I said we do get referrals, often for patients who want to be on testosterone because their testosterone is low.
Yep.
But as part of their evaluation for that, they check their PSAs. If their PSAs are high, then they'll send them to us because we need to consider that person for a prostate biopsy, because as you mentioned, the testosterone is going to make that prostate cancer grow likely. And we want to make sure that if they have prostate cancer, we find it out and get it treated before we ever, let that person go on testosterone.
And now we have to think about a new level of high. When you talk about putting patients on testosterone, it's on the floor, so I can go ahead and give it to you. But now that's a whole nother discussion around that based on what we've heard this evening.
Yes, absolutely. You want to make sure that they don't have prostate cancer before you start treating with prostate for testosterone.
Exactly. And that's why I send people a lot of times to see a urologist when even when they're at 3.5, that was
Oh
just
yeah,
not because I
absolutely.
knew any better, but it was because like, you're too close. I'd rather that decision be made by the urologist in
Yeah.
terms of treatment. Real quick, because I know we're getting short on time, and like you said, we always trying to keep our guests in terms of giving them an opportunity to be with their family. We took enough away at a time. But Dr. Jones did want you to discuss, if you can, a brief discussion on robotic prostatectomy versus RT, meaning radiation therapy.
Yeah, like I said, that's really outside of the scope of what we're going to talk about tonight because that's really treatment.
Right.
But a prostatectomy is basically taking out the whole prostate, whereas radiation is treating the prostate where it is. So you're basically sending radiation beams directly through the body into the prostate, and the prostate cancer cells are more sensitive to the radiation than the normal cells are. So they suffer DNA damage, they cannot repair it, and so over the course of time, they die off. As they die off, the PSA comes down, and that's the way that you know that the cancer has been treated. If the PSA levels out and then starts to go back up again, then you have to figure out, okay, is this inflammation? Because the prostate's still there. Is this inflammation? Is it infection? All the stuff from before, is it that? Or is it the cancer coming back? And then you might end up having to do a biopsy at some point to confirm that. But we also now have a PSMA PET scan, prostate specific membrane antigen PET scan. It's very sensitive for detecting prostate cancer in the prostate. And one of the indications for getting that test is failure of a treatment. One, like if you already had something treated and the PSA starts rising, so failure of treatment is an indication to get a PSMA PET scan. The other indication for that is when you're first diagnosed, if you have aggressive prostate cancer, then that scan is indicated as well because it's very sensitive for showing if there's cancer spread outside of the prostate. That's primarily how it's being used.
So
But
we don't
again, like
see
I
it.
said,
We're not using it much for in the screening process, for sure.
no, we're not, and it's kind of frustrating because I
Yes.
absolutely think it would be helpful. But
Yes.
you know how it is, the insurance companies are not going to pay for something that is that expensive, right out of the box. Everybody's
Right.
got to make their money first, and then they'll somehow end up becoming like the MRIs now because we couldn't get MRIs at first either. Remember that?
Yeah, I remember.
You had to get prior authorization all the time, and sometimes we still have to get it. But
Yeah.
I think eventually we'll get to the point where the PSMA PET scan is going to supplant the MRI for that reason.
Well, Dr. Williams, as I always say, an hour is not enough, but it's what we got. So, and so I'd like to know from you, what is the single most important message you like men and their loved ones to know about prostate cancer screening? If you had, I'm not going to say a one-liner, but kind of a basic paragraph of the most important thing you want to deliver this evening in terms of a message about prostate cancer.
I would say know your risk, meaning that am I average risk or high risk? Remember, the average risk patients are not patients who have family histories of prostate cancer and are not African American. And so if you're in the high risk group, you want to know that because you need to start getting screened at age 40, as opposed to average risk. You can wait till like 45 to 50 or something like that to get screened. So know your risk, and then know that you need to get a PSA and a digital rectal exam as your initial screen too. Okay, just those two things. So know your risk if you're average risk or high risk, and then know that you need a rectal exam as well as the PSA as your initial screen for prostate cancer. And also, I guess another third thing is that if your PSA is greater than 3, you need to get somebody to check that out.
Right. You need more of an expert than I am for sure. All right, Mr. Jackson, you got anything you want to say about to Dr. Williams and our audience?
Well, first of all, I want to say thanks to Dr. Williams for coming on. It's given us a great deal of information. I'm not surprised at the level of his professionalism, so thank you very much. I just want to echo one of the things that I think I've heard him say, and I've heard others say, is that there's a great value in arming ourselves with the information and knowledge. A lot of questions have been brought up or have been said about, how do we get more African American men to know their numbers and to get these stresses and screenings. I believe we have to make the conversation not a hush hush, not a secret conversation. Men can have these conversations with their friends, the spouses and loved ones can have conversations with them. It is something that needs to be discussed. It is obvious through what Dr. William has said that early detection gives you more options and gives you more power. So we want everyone to be aware of that.
All right. So one last thing I'm gonna ask you, Dr. Williams, and we're gonna let you go. Where can people go and not just men, but where can anyone go? They can give them more or less some great information and good resources about prostate cancer, its prevention and diagnosis.
I would have to look that up because I have some books in my office from the Prostate Cancer Foundation, but I guess they could go online to the Prostate Cancer Foundation and look that up and find that kind of information because there are resources out there that can give them that information. I think the Prostate Cancer Foundation is one of them. So you can just go online, Prostate Cancer Foundation, and find that information.
And I know sometimes you do clinical studies, but that's another whole subject matter that we're not going to discuss this evening. But let people be aware that there are plenty of studies out there that they may be able to participate to help with their loved ones and others in society. So we can come back to that at some other time and talk about that. Well, Dr. Williams, it's been a pleasure, as I figured it would be. It's been my great honor to have you on again on our program. Obviously, you're my go-to guy when it comes down to prostate cancer and other urological cancers. Let's not forget that Dr. Williams, we may have talked about prostate cancer this evening, but he's also has a great level of expertise in urological cancers. So if you ever need it, you can contact Paul for the Truth and we can get you his information that you can give your primary care guy if it ain't me, because I already know how to get you to it. But if it ain't me, you can contact us and we'll get you the info for Dr. Williams and so that you can have a discussion with your primary care person. I don't want to say guy, but person. I appreciate it. As usual, we want to thank everyone for joining us this evening. I think we've had a very enlightening conversation about prostate cancer. And as we said from the beginning, we basically wanted to have a discussion about prostate cancer, not so much about the treatment for prostate cancer. That will be another show in which, we will try to make sure that hopefully we can get Dr. Williams back at a later date and have that discussion. To all out there, we want to thank you again for joining us on on Pause for the Truth, as well as help us in thanking Dr. Williams for providing us with his expertise. Join us next week, same time, same station. And to all, I say a good night.
Good night, everyone.
Good night, everyone. Thank you.
We appreciate you spending time with us on Pause for the Truth. Ms. Jocelyn Turner and Dr. Rogers Kane are grateful for your support. Don't forget to like us on Facebook, catch us live on Twitch, and most importantly, subscribe on YouTube. A big shout out to Tyrone Jackson at Call Tyrone IT Services for keeping us connected. Join us every Tuesday at 6:30 p.m. Eastern Standard Time for more enlightening discussions. Thanks, and see you next week.